Welcome to this ACEs Aware webinar. This is the first since UCAAN, the UCLA-UCSF ACEs Aware Family Resilience Network, was selected by the California Department of Healthcare Services to continue the implementation of the ACEs Aware initiative. We're excited to give you an update today on the initiative and to introduce you to UCAAN. My name is Emily Williams. I'm the CEO of UCAAN, and I will be your moderator today. Before we get started, a few housekeeping notes. This webinar is being recorded and will be posted to the ACEs Aware website in the coming days. If you have questions for the panelists, please enter them into the Q&A feature, and we will try to address as many of them as possible during the Q&A section of the webinar. And now, here's an overview of today's agenda. I will provide a brief overview on ACEs Aware and UCAAN, which will be followed by a panel discussion with three of UCAAN's leaders, Doctors Shannon Tyne, Eddie Machtinger, and Makai Owen. Then we'll take questions from the audience before closing with slides that provide links to various resources on the ACEs Aware website. Since ACEs Aware was launched in 2019, in recognition that ACEs and toxic stress are a public health crisis, the work has only become more necessary. A lot of us are seeing the urgency in multiple ways, such as mental health challenges faced by our youth and caregivers, and the alarming rate of burnout within the healthcare workforce. The good news is, toxic stress is a treatable health condition. By screening for ACEs, assessing for risk of toxic stress, and responding with evidence-based interventions and trauma-informed care, we can significantly improve the health and well-being of individuals and families. I'd like to take a moment to thank all of you for the work you do to improve the health and well-being of all Californians. Together, we can address this public health crisis and lead a national movement to ensure everyone is ACEs Aware. Now I'd like to give a quick overview of the ACEs Aware initiative for those of you who are not familiar with it. I'd like to share also how UCAAN is anchoring the initiative at the University of California. Thanks to broad support from the California legislature and Governor Newsom's foundational investment in this effort in 2019, California is leading the way towards significantly improved health and well-being across the state's communities. ACEs Aware offers Medi-Cal providers training, screening tools, clinical protocols, and payment for ACE screening. Dr. Nadine Burke-Harris, California's first Surgeon General, set the bold goal to reduce ACEs and toxic stress by half in one generation. Her leadership and the leadership of Dr. Devika Bhushan, who served as acting California Surgeon General until earlier this month, in partnership with Dr. Karen Mark of the Department of Healthcare Services, has laid the groundwork for the ACEs Aware initiative to advance systemic reforms that recognize and respond to the effects of ACEs and toxic stress on health. We look forward to working with Dr. Diana Ramos, California's new Surgeon General, who took office on September 1st. So what is the ACEs Aware initiative about? It's about developing, promoting, and sustaining evidence-based methods to screen for ACEs, treat the impacts of toxic stress and trauma, and help patients heal. We bring communities together in new and innovative ways to address one of the most harmful, persistent, and expensive health challenges facing our state and nation. And we leverage academic and community resources to transform clinical practice through quality improvement, training, and technical assistance. The ACEs Aware goals and objectives are to raise awareness by training and expanding awareness among Medi-Cal providers on ACE screening and response, to effect practice change by supporting implementation of ACE screening and response for Medi-Cal providers, and to establish and expand networks of care and support development of a trauma-informed network of care. Why screen for ACEs? Well, routine and universal ACE screening helps clinical teams provide more effective and equitable healthcare. Screening results can be used to provide targeted clinical interventions, as well as offer greater compassion, patience, and the opportunity for relational healing. ACE screening has been successfully integrated into a wide range of clinical settings, including pediatric primary care, adult primary care, family medicine, and women's health and prenatal care. The core training offered by ACES Aware is the Becoming ACES Aware in California online training. This training is for clinical teams, but anyone can take it to learn more about ACEs and toxic stress. Completing this training or any of the other core ACES Aware trainings enables Medi-Cal providers to self-attest, allowing them to bill and be reimbursed $29 for each screen of a Medi-Cal beneficiary. You can access the free online Becoming ACES Aware in California training at training.acesaware.org. And we will share this link again at the end of the webinar. Since the ACES Aware initiative launched in 2019, tens of thousands of California Medi-Cal providers have completed the Becoming ACES Aware in California training, and nearly 1 million screens have been conducted for Medi-Cal beneficiaries. Next, I want to share some information about community grants. ACES Aware has distributed more than $64.5 million in grants across California since 2020. This investment in community grants supports clinics to translate newly available funding into increased staff and services to respond to ACEs and toxic stress. Our first round of grants supported provider engagement, provider training, and communications. The second round of grants supported network of care planning and implementation. This slide shows the number of each type of grant that was awarded. On September 16th, ACES Aware announced a new slate of awardees for our third round of grants, known as Practice. The goal of Practice is to increase the workforce and services needed for primary care clinics to expand and sustain screening and response to ACEs and toxic stress in local communities. We plan to do this by strengthening partnerships among clinics, community-based organizations, and Medi-Cal managed care plans, by developing new and sustainable evidence-based services to fill gaps and address toxic stress and ACE-associated health conditions, and expand the workforce to support ACE screening and address toxic stress and ACE-associated health conditions among Medi-Cal beneficiaries. The 25 awarded grantee teams from 15 California counties serve a wide range of diverse patient populations. And this map shows the demonstration, shows how they are distributed throughout the state. Under this funding opportunity, 2 cohorts of grantees were awarded, Pathfinders and Catalysts. Pathfinders are in the early stages of ACE screening, incorporating trauma-informed practices into care and forming community partnerships. Catalysts already have ACE screening, toxic stress response, and trauma-informed care practices integrated into their operations and have existing partnerships with CBOs. Grantees will participate in a learning collaborative, which offers technical assistance, training, tailored web discussions, access to subject matter experts, resources, and peer-to-peer learning to support the teams in achieving their goals. You can visit acesaware.org for more information, including a full list of all the grantees. Now let's take a look at the results of our earlier poll. Who's here today? Okay, so it looks like we have about 1/3 of the population from Los Angeles, Orange, San Diego, and Ventura counties. We also have 1/4 of our respondents or our attendees from the Bay Area, with a good 15% who are outside California. Really interesting. And then about 10% who hail from the North Central region, including Sacramento and San Joaquin, and then distributions throughout the rest of the state. And the question, what is your relationship with the ACES Aware initiative? It looks like the majority of folks are fall into the other category. So that'll be interesting to see what different affiliations people have. And it looks like about 17% are newsletter subscribers. Thank you very much. We will provide information at the end of this webinar on how to subscribe to our newsletter. 13% are round 1 grantees. And if we add up all the grantees, it looks like we have about 30% of our attendees who were a grantee or are a grantee, and then about 15% from various government agencies. And then a good number of you, 14%, have no prior relationship with the ACEs Aware Initiative. We welcome all of you, and we will be providing resources so that you can dive deep into the areas that you're interested in learning more about. Thank you so much for answering our poll questions. And now I'd like to give you a brief overview of UCAAN. In October 2021, DHCS contracted with the newly created UCLA-UCSF ACEs Aware Family Resilience Network, or UCAAN, to continue the implementation of the ACEs Aware Initiative. DHCS provides the funding and oversight in partnership with the Office of the California Surgeon General. UCAAN is a multi-campus initiative that leverages the substantial interdisciplinary resources of the University of California, Los Angeles, and the University of California, San Francisco campuses. 4 values inform UCAAN's work across all departments, advisory groups, and committees. Whole person and whole family wellness. This includes the whole family unit in the care we provide, including dyadic care. Health equity. We recognize the role that structural discrimination has played in determining inequitable health outcomes, and we ensure access to screening and services for all Californians. Community engagement, ensuring that we reach communities that have been historically marginalized and under-resourced. And systems alignment, aligning resources and systems of care to ensure that clinicians, families, and communities are able to overcome the impacts of toxic stress. The ACEs Aware Initiative can leverage the substantial leadership and resources of 2 world-renowned campuses to transform clinical practice and build a sustainable workforce. UCAAN develops, promotes, and sustains evidence-informed responses to prevent and help all patients heal from the impacts of trauma and toxic stress. UCAAN is focusing on priority areas, including ongoing efforts to screen more children and adults for ACEs, expanding training for Medi-Cal providers to increase the number of ACE screenings, and capacity building across providers and clinical sites to ensure appropriate and effective responses to positive screens. In March 2022, UCAAN launched 16 pilot projects led by UCLA and UCSF faculty. Their work is expected to be completed by June 2023. The goal of the pilot projects is to advance education and training in ACE screening, toxic stress treatment, and in the prevention and treatment of ACE-associated health conditions. These pilots are addressing crucial gaps that have been identified in our field. They allow us to bring into the initiative many scholars from aligned areas of inquiry who have not previously been involved in ACEs. Priority topics include examining ACE screening and toxic stress response, interventions, and outcomes of ACE-associated health conditions or ACE-associated health inequities, including asthma, obesity, and diabetes. Improving training and developing workflows for screening in specific settings and populations, such as perinatal and farm worker clinics, and using stress busters in innovative ways. As a reminder, we will be sending this slide deck to all attendees, so you will have an opportunity to take a closer look at the pilot projects. And now it's my pleasure to introduce our 3 panelists, who are leaders at UCAAN and experts in trauma-informed care and ACE-associated health conditions. First, Dr. Shannon Tyne, who is a co-principal investigator of UCAAN. Dr. Tyne is a vice chair in the Department of Pediatrics at UCLA Health. She is the chief of pediatrics at Olive View UCLA Medical Center and the director of pediatrics for the Los Angeles County Department of Health Services. Dr. Tyne is also a board-certified pediatrician with leadership experience. She earned a BA in psychology from Yale College and an MD from Brown University. She completed her residency at UCSF and served as a pediatric chief resident at San Francisco General Hospital. Hello, Dr. Tyne. Dr. Edward Mochtinger is also a co-principal investigator at UCAAN. He is a professor of medicine and Director of the Center to Advance Trauma-Informed Healthcare and the Women's HIV Program at UCSF. Dr. Mochtinger is a primary care doctor caring for women living with HIV. He earned an MD from Harvard University and completed his residency in primary care internal medicine at UCSF. Welcome, Dr. Mochtinger. Dr. Makai Owen is Senior Director of Clinical and Academic Programs, Health Equity for UCAN. Dr. Owen has been a longtime advisor to the ACEs Aware Initiative and recently joined UCAN. Prior to joining UCAN, Dr. Owen was an assistant clinical professor in the Department of Pediatrics at UC Davis Health System. Dr. Owen earned an MD at UCSF, completed his pediatric residency at UC Davis, and completed his fellowship in community and societal pediatrics at the University of Florida College of Medicine, Jacksonville. He also recently completed the Posen Commonwealth Fund Fellowship in Health Equity Leadership at Yale University. Welcome, Dr. Owen. So we have some questions for all of you, and we're excited that you can be here to share your thoughts and your experience about UCAN, ACEs Aware, and toxic stress. My first question is for Shannon and then Makai. As pediatricians, what inspired you to focus on adverse childhood experiences and trauma-informed care? Shannon, let's start with you.
Thanks, Emily. It's great to be here. For me, my passion for supporting children who've experienced trauma stems from my childhood. I grew up in a family where my parents opened our home to a foster child, and my youngest brother, joined our family as a foster child and then an adopted brother after a really rocky first 2 years of his life. He had experienced perinatal substance exposure, neglect, had a real delay in his motor skills and really poor attachment. But he came to our house and got love and support and Nintendo to help his fine motor skills and a really supportive family, and he was able to thrive in our household. As I went to medical school, I would remember these experiences, and I was really drawn to pediatrics. I love the potential that I see in every kid. They start as blank slates, and even faced with real challenges like the ones my brother had, they can bounce back. And for me, engaging with kids and their families to support them heading in a positive direction through well child visits, providing vaccines, sitting on the floor, teaching a kid how to roll a ball, and all of the things that we do in primary care that now have this lens of a trauma responsive support. This can really help kids thrive. I still work with lots of foster kids and other kids who experience challenges, things like economic hardship or exposure to violence. And while their challenges are real and not always easy to address, the resilience still inspires me. And I'm so honored to work with a team that continues to explore ways to help kids and their families respond to toxic stress and support building resilience. And the ACEs Aware movement really helps us put a framework around this, and it keeps me really excited.
Thank you so much, Shannon. Makai.
Thanks, Emily. So I think I was inspired to do this work before I even knew what ACEs, toxic stress, or trauma-informed care was. Growing up as a Black kid, I was always taught that I may not get second chances. Any mistake that I made could be magnified and could change the trajectory of the rest of my life. And that concept and the idea of how harsh and unforgiving the world can be for children of color always stuck with me. So I always knew that I wanted to pursue a career that was focused on supporting children, and especially children of color. And I wanted to work to ensure that all children had a fair chance to reach their full potential. So once I decided to go into medicine, I knew from day one that I wanted to be a pediatrician. And I approached my pediatric education and training through the lens of health equity. And I was really drawn to life course epidemiology, the science of childhood adversity, and the general understanding that the environment and experiences of childhood have a profound impact on the health and well-being of individuals across a life course. And the more I learned, the more personal this work became for me. Understanding the disparate impact of trauma on children of color, on communities of color, and how that disparate impact is rooted in historical and ongoing injustices, like structural racism, really pushed me to want to do this work and gave this work more meaning for me. Clinically, I now practice in a youth detention facility, and much of my advocacy work is focused on juvenile justice reform. When taking care of kids impacted by the justice system, you see very quickly that virtually all of them have been deeply impacted by trauma. Most of them have experienced many forms of trauma, and most have experienced trauma from a very young age. In doing this work, you begin to better understand the impact trauma has had on these young people's lives, and how for many of them, trauma is a big part of what led to their involvement in the justice system. So for me, focusing on ACEs, childhood adversity, and toxic stress gives me the opportunity to provide better, more relevant care to the young people I take care of. And focusing on ACEs and childhood adversity also helps to anchor my advocacy work and makes me a more effective advocate when advocating for systems change and calling for systems that are more supportive of kids and more responsive to the needs of children and adolescents that have been impacted by trauma. And I continue to find deep meaning and fulfillment in this work.
Thank you so much, Makai. My next question is for you, Eddie. As a primary care doctor focused on adults, what has been your motivation?
Thanks, Emily. So I'm a adult primary care internal medicine doctor and have been taking care of women living with HIV for my whole career. Before effective medications for HIV were developed in 1996, most deaths in our clinic were from AIDS. But then effective medication came along and my patients still kept dying, not from AIDS, but from substance use and overdose, from depression and suicide, and violence, diabetes, and heart, lung, and liver disease, and at rates far higher than the general population. And we had an epiphany that the common denominator driving these preventable illnesses and deaths and so much suffering, and what led many of our patients to getting HIV in the first place, was a shared history of trauma that started when they were kids and continued into their adulthood. And ultimately, we came to see that most preventable illness and death, and almost every disparity in health, exists because of an imbalance between trauma and protective factors. And to us, that understanding was incredibly exciting. It helped demystify our patients, why they're struggling to take their medicines or lose weight or drink less or break up with abusive partners, why some patients behave the way they do and were reactive or dissociative or distrusting. Understanding my patients in this way helped me as a clinician be more patient and compassionate and connect more deeply with them. And we thought that if our program could refocus itself on addressing adversity and increasing protective factors as the foundational principle of care, we could meaningfully improve the experiences and outcomes of care for both patients and families, and for us as providers and staff.
Thank you, Eddie. My next question is, how does this work on ACEs align with efforts in California to overcome healthcare disparities? Let's start with Makai, and then we'll go to Shannon.
So for me, prior to moving back to California, I was the pediatric medical director for a federally qualified health center in an economically marginalized, predominantly African-American community in Florida. And as I said earlier, I now practice in a youth detention facility. So my career has really focused on caring for children and adolescents from marginalized, vulnerable, and minoritized backgrounds. Children and families that are deeply impacted by the social determinants of health and awfully deeply impacted by ACEs, childhood adversity, and toxic stress. And these experiences have taught me many lessons, but two are especially relevant to this question. First, I learned that traditional primary care, at least in the way that I was trained and the way that I was practicing, was failing to meet the needs of the children and adolescents I was caring for. Clinically, I felt ill-equipped to provide optimal care for many of my patients. I wasn't prepared to identify risk of toxic stress. I didn't yet understand how I could help patients heal from toxic stress. And the clinic and community often did not have the resources needed to support patients and families with the issues that they were facing. Second, this clinical experience has reinforced what I already knew, which is that clinical medicine is necessary, but not sufficient to achieve health equity. Achieving health equity will require innovation in healthcare and changes in healthcare delivery, but it also requires work in all sectors of our society to address the structural and social determinants of health and the root causes of inequities in health and well-being. And what's exciting is that it feels like California recognizes this, and California is leading the way in terms of charting a new path towards health equity in healthcare and in other sectors. There's too many examples to name them all, but I'd like to point out a few. So first, recognizing the decades of work by patient advocates, community members, and community-based organizations focused on improving health and well-being outcomes for marginalized populations, and the community-based leadership in the fields of trauma, healthcare, education, social services, and other sectors across California. That work continues and will drive much of the success of California's progress towards health equity. Now we also have UCAAN and the ACEs Aware that focuses on preventing ACEs and helping patients heal from toxic stress. We have CalAIM and its mission to transform Medi-Cal to improve quality outcomes and reduce health disparities. We have the California Office of Health Equity, whose mission is to promote equitable social, economic, and environmental conditions to achieve health equity. We have the Children and Youth Behavioral Health Initiative, a multi-billion-dollar advancement to enhance and expand the systems that support behavioral health for children and youth. And we even have the California Reparations Task Force, charged with studying the institution of slavery, its lingering effects, and developing reparations proposals for African Americans. And there are many more examples of health equity programs and initiatives in the state that can be pointed to as examples of the amazing work that's being done in California. Together, these examples really show that California is leading the way on these issues. And though there is still a long way to go and much work to be done, it's really exciting to know that UCAN and ACEs Aware is part of a much greater whole in terms of working to achieve health equity in California. And I'm really excited to see how these initiatives and strategies can come together in the future as part of a comprehensive interdisciplinary approach to achieve health equity in California.
Thank you, Makai. Shannon, do you have anything to add?
Yeah, just something that I always say to my residents when I'm in the training situation: if you always do the same thing every time, you're going to do your best to decrease bias. And I really feel strongly that health disparities can worsen when different people are treated differently based on incorrect assumptions. And in the case of ACEs, you can't tell if someone has ACEs by looking at them. We have our ideas of who has ACEs, but those aren't always right. For me, preventive health must acknowledge that everybody deserves to be on the same playing field. And like I say to the residents, do the same thing every time. One thing I appreciate about the ACEs Aware initiative is that we have the option to screen everybody, not just people who look like they have high ACEs or who fall into a particular group that people think might have high ACEs. As the movement advances and uptake becomes more universal, it's my hope that ACEs and screening for toxic stress and other social determinants of health will become as acceptable as taking a blood pressure. Once we make screening for trauma a part of health promotion and in a manner that doesn't marginalize anyone, we'll all be able to respond better in a way that doesn't disproportionately impact different populations.
Thanks, Shannon. Eddie, anything to add?
Just that health disparities aren't genetic. You know, Black women are 3 to 4 times more likely to die in childbirth. Black infants are twice as likely to die as infants than white babies. Half of Black transgender women are currently living with HIV. Half of Black gay men will become HIV positive in their lifetimes. American Indians have the highest rates of cigarette smoking and among the highest rates of suicide. Latinx youth have the highest rates of childhood obesity, on and on. None of these realities are genetic. They're all due to the lived experiences of Black, Native, transgender, gay, and Latinx people in this country, which include very high rates of trauma and far too protective factors. And our movement in ACEs Aware understands that health disparities result from disparities in the distribution of adversity and protective factors. And unless we have a foundational understanding of the origin of health disparities, I don't see how we're ever going to overcome them. And for all of us in healthcare to live up to our role addressing health disparities, I think primary care itself needs to become a protective factor for our patients and families that interrupt the impact of toxic stress on preventable illness and preventable death. And that's what we're all trying to accomplish together with all of you in the ACEs Aware initiative.
Great. Thank you, Eddie. So, Eddie, building off what you just said, where do you think we are in the movement to address ACEs and toxic stress as a central part of the primary healthcare system?
Well, there's a rock solid correlation between ACEs and other forms of trauma with health outcomes as adults and children and with health disparities. That is known. It's there, known, period. We also know from many demonstration projects, from research studies and years of clinical experience that patients have better outcomes and doctors have better experiences and are more fulfilled in their work if we address co-occurring trauma and PTSD that accompanies most of the difficult conditions we treat in primary care. So the question facing us now is how to take what we know from research studies, our own experience at demonstration projects, and bring that into very complex, very busy, very degraded primary care clinic, and use that knowledge to change how we deliver care. And I think probably even more importantly, to measure those changes and their impacts on health outcomes and health disparities so that we have the data necessary to sustain and scale this movement.
Thank you so much. We now have time to open up to questions from the audience. And so we received dozens of questions even before today. So we wanted to select some of those questions and ask them and pose them towards the panelists. And then we are also getting some questions in real time. So we will try to take as many of those as possible. A number of them are asking about the slide deck. We'll be sending that out to all people who RSVP'd, whether you attended or not, and please feel free to share it. We will also make materials available on the website, including a recording of this webinar so that you can watch it again, or if you need to leave early, you can watch the end of it, and please feel free to share that. So first, I didn't realize, Shannon and Makai, did you want to add to Eddie's response for that last question? Apologies, I didn't give you a chance to do so if you wanted to.
Sure, I'll just add a little. This initiative launched 3 years ago, and we've seen a really impressive increase in screening across the state. And I support this, but we still need to advocate for expanded screening, and we certainly need to make it easier to respond, both in the clinical setting and through community referrals. I think there are 2 ways we can support making screening for toxic stress central to primary care, just like Eddie mentioned. The first is by helping healthcare providers and frankly, all Californians to better understand the role of toxic stress in health. I think the pandemic has really helped us all understand trauma and exposure to trauma collectively. And that's actually been an unexpected good thing about the pandemic. We all relate to each other and our trauma a little bit better. But in addition to helping people better understand the role of toxic stress, we also need to look at specific health conditions that are particularly impacted by exposure to toxic stress, and look at how to treat those conditions better so that people will have better health outcomes. Together, I think these approaches will help us quantify the impact of toxic stress on health outcomes and allow us to better provide care in the clinic setting and through community outreach. One thing I'm really excited about with UCAAN is our reach into training programs, for example. We're working with medical schools, nursing schools, mental health programs, and even school-based health programs to really think about how we can expand understanding of toxic stress and trauma-informed care. And as we provide our emerging workforce with tools to identify and address toxic stress incorporating screening and response will become broader and more widely accepted. And as I mentioned before, will be offered in the same way to everybody.
Makai, would you like to add anything to that?
Yeah, I agree with what Shannon said, and I think that we've come really far, but we still have a long way to go. And, many clinical teams still may not feel comfortable screening for ACEs and risk of toxic stress. Many teams may not understand their role in treating toxic stress. So there's a lot of work to do in terms of educating, training, and supporting our healthcare workforce in doing this work. And, that's one of the primary goals of UCAAN and ACEs Aware. But I also think it's important for us in California not to be discouraged by where we are in healthcare in terms of preventing and treating toxic stress. We know that innovation in healthcare can take a long time. And I don't think that anybody involved in UCAAN or ACEs Aware or trauma work more broadly thinks transformation is going to be easy. But I think we all know how important it is. We all know the pervasive impact of ACEs and toxic stress and the impact it's having on children, on adults, on families, and communities in California. And some of the issues we face in our healthcare system or our society can feel so complex that we don't know where to start. But knowing that the work we are doing in UCAAN and ACEs Aware and the trauma responsive work that is being done by advocates across the state is connected to broader structural changes and statewide health equity initiatives is very heartwarming for me, and it really motivates me. For me, it makes me much more optimistic for the future, not only the future of healthcare in California, but for the future of the kids that I take care of, the kids who experience trauma and toxic stress, and the next generation of kids who hopefully don't experience as much childhood adversity and toxic stress as the generation of kids who came before them.
Thank you both for adding on to that answer. And now here are some questions from the audience. The first one is for you, Eddie. And the question is, how often are adults being screened for ACEs?
Thanks, Emily. So screening adults for ACEs is an earlier phase innovation than it is for kids, but this is changing. Roughly 15% of all screens were conducted among adults, and that's age 21 through 64. So looking at just the time period between when we first started collecting data in January 2020 and September 2021, this amounts to over 100,000 unique adult Medi-Cal beneficiaries being screened. Because ACEs happened in the past, screening adults for ACEs can only be reimbursed once per provider. This is one reason that the numbers of screens is less among adults than children. But any new or additional providers can be reimbursed for screening. So every provider of care to each patient throughout his or her life can understand this information. And I'll just say a couple more things about adults. So as a primary care doctor taking care of adults, screening adults for ACEs creates a moment with a patient that feels to me like a short meditation for both of us on the origin of most health and social conditions that we're trying to address together. That these conditions result from a lot of trauma and far too protective factors, far too few protective factors. In these moments, I'll say things like, of course you're struggling to lose weight and stop smoking, because look at all the stuff that you've had to cope with. Having this moment to reflect helps ground me, allows me to be more compassionate and patient. And I think for my patient, it helps them blame themselves less and feel less stigmatized by what's going on with them. I tend to end each of these brief conversations by asking my patient, tell me more about the sources of strengths that have allowed you to sustain yourself and be here with me today, which ends up feeling very positive and lets me know about strengths and resources that we can access together to overcome their current problems. And this exchange may take 5 or 10 minutes, but it feels like it deepens my relationship with that patient. And ultimately, I hope that by deepening my relationship with the patient, that they will feel safe and comfortable revealing themselves to me in ways that are really important, letting me know that they may not be taking their meds that I've prescribed, or that they're using substances, or that they're in an abusive relationship. And it's only when patients feel comfortable revealing themselves to us that we can address many of the factors that lead to such high rates of health disparities. And I'll just end by saying screening for ACEs is not the only way or an entirely sufficient way to assess the impact of an individual's kind of experience of adversity. But it's one way that can be integrated into the clinic flow that can help catalyze many additional changes, like embracing a clinic-wide process of becoming trauma-informed or adding certain missing services that can together feel like a meaningful improvement in the experiences and outcomes of care for patients and us as clinicians. And that's been my experience adopting trauma-informed healthcare, and has been my experience now that I've included screening for ACEs.
Thank you, Eddie. Makai, the next question is for you. All right, just lost it here. Here we go. How should federally qualified health centers, also known as FQHCs, with behavioral health integrated into their clinics, do screenings? Should they be done on the primary care or behavioral health side?
It's a great question. And first, I just want to say, I think it's great that many health centers are moving towards more medical and behavioral health integration and true integration, and that hopefully we see more medical behavioral health integration in health centers going forward. Second, I think it's the workflow for screening can and should vary depending on the clinic, the staffing model, and the resources, right? So I think that what behavioral health integration looks like at one clinic or one clinic consortium may be different than it looks at another clinic consortium. So I think there's no one particular answer that can kind of tell clinics, how they should do it for their particular workflow. But one thing that, I really want to point out with this question, I think that's really relevant, is, we recommend screening for ACEs as a way to identify for risk of toxic stress. And part of that assessment is evaluating for the presence or absence of ACE-associated health conditions to help determine, whether or not a patient may be being impacted or at risk of being impacted from toxic stress physiology. So, it can vary about when it happens in the process, but it is important that I think primary care teams or medical providers be involved in the process. It's important for medical providers to be involved to evaluate for the presence or absence of ACE-associated health conditions. But it's also important for medical providers to be involved in helping to treat toxic stress and monitoring for improvement in those ACE-associated health conditions as part of the joint treatment plan. So I think keeping those considerations in mind is really important, but the specific workflow and who conducts the screen may look different for different clinical settings.
Makes sense. Thank you, Makai. The next question is for you, Shannon. Is there a focus placed on prevention of ACEs, or is the focus solely on the identification of ACEs and the treatment of the resulting toxic stress and ACE-associated health conditions?
That's a great question, and I think it changes whether you're working with kids or with adults. ACEs, by their definition and in our algorithms, are things that happen before your 18th birthday. So while identifying ACEs is a key component of our screen, treat, and heal approach, and that's how we approach this with kids, screening children at a young age does provide the opportunity to both identify existing ACEs and to provide support to mitigate the response to any ACEs that already exist, but also to help get someone into an environment where you can prevent the occurrence of future ACEs. So in pediatrics, there's a big prevention component related to the adverse childhood experience itself. With adults, I still think that prevention is a key. It's just not a prevention of the ACE itself, right? It's a prevention of the impact of those adversities from childhood on the future. And so I like to think of the whole ACEs aware movement as a prevention strategy, where in some cases it's to prevent the ACEs themselves, but in most cases it's really to prevent the impact of toxic stress.
And Emily, can I just add one thing? from the perspective of an adult provider, one of the best ways to prevent ACEs in kids is to take care of parents and help them treat their own mental illness, their own substance use disorder, help them not die, help them not go to prison, help them be safe and strong parents so that they can help prevent the intergenerational transmission of ACEs to their kids. And that's a huge role for adult providers of care in the ACEs Aware movement.
Thank you. Okay, Makai, for you, there have been a couple of questions about tracking more detail on ACE scores, such as through risk stratification and by location. Can you comment on any of this?
Another great question. So I think ultimately, we think it's very important to monitor and track the data and make it available. You know, data like the number of providers that have completed the Becoming ACEs Aware training, or the number of clinics that are screening for ACEs and toxic stress, and areas in the state where screening is occurring more than others. You know, the number of patients that are being screened, and also the prevalence of ACEs and ACE-associated health conditions in communities across the state. And, you know, I think we're actively working on ways to present that data and make it and share the information publicly so the data can be used in a way to help support communities and advocates across California. But at the same time, you know, I think we recognize that the data can be misinterpreted and it can be misused, and that individuals and advocates across the state may have some concerns about sharing that data and what that data looks like. So I think we want to be really mindful and respectful of those concerns, and really be thoughtful about how and when we share data, and make sure that it's shared in a way that is both helpful and productive to advocates and policymakers in the community, but is also very mindful and responsive to any concerns that people may have about, you know, sharing this information at the population level.
Great. Eddie or Shannon, anything to add? No? Okay, great. A couple more questions from the audience. Does ACE screening also include screening for positive experiences and protective factors? And I'll open that up to any one of you who wants to answer.
Emily, I'll just start. You know, an ACE score does not define an individual. Someone is not defined by their adversity. The ACEs Aware risk assessment algorithm, if you read it, it's in our core training, includes screening for adversity alongside screening for signs and symptoms of ACEs-associated physical and health conditions, as well as an assessment of an individual's strengths and resources, otherwise known as protective factors. And it's only in this way that providers can make a holistic, individual assessment and tailor individual care plans for each patient. We have an amazing colleague who's a legendary trauma psychologist, Alicia Lieberman, and she describes this method of assessment as triads: trauma inquiry for adversity, distress, and strengths. These three necessary ingredients to tailor an individualized care plan. And the ACEs Aware algorithm is aligned with that method.
Shannon, anything to add to that answer?
Yeah, I'll just add that, so before UCAAN and before I was officially engaged fully with ACEs Aware, we had a project that we worked on in LA to roll out ACE screening. And we've rolled it out at a bunch of clinics and are now providing technical assistance to other clinics across the state through UCAAN. And what we're seeing is, as we help people roll out the screening, we're moving much more toward an emphasis on asking resilience questions and focusing earlier on positive experiences or protective factors. And I think that's where the movement's headed. It doesn't mean that we don't want to understand adversity, but we also at the same time want to understand what strengths and positive experiences you bring to the table that can also help mitigate toxic stress.
Great. Excellent. Okay, before I go on with a couple more questions before we wrap up, I want to encourage all attendees to fill out the webinar evaluations so we can know what worked today, what you disliked today, and also to get your thoughts about topics for future ACEs Aware webinars. So now our last couple of questions. First of all, I'd like to clarify a couple of things about questions that have come in. One question that came in asked about the grantee map and pointed out that Northern California didn't seem to have as many grantees. So I'd like to clarify the map that we shared with you was a map just for this round of grants. So it only represents the 25 practice grantees. If you go to acesaware.org, you can take a look at the maps that included the round 1 and round 2 grantees so that you can see more of an accurate distribution of grantees throughout the state of California. A couple of other things I wanted to acknowledge are our guests who are here from outside California. And so I wanted to acknowledge we've got folks from Iowa. We've also got folks from Texas, as well as, let's see, a couple of other states, Georgia. And so I just wanted to say thank you so much because many of you have expressed interest in starting up a movement in your state or leading a movement. And we do have reports from 9 different states of leading a movement similar to ACEs Aware. And so we're so excited. They're in varying stages, but we invite you to email us at questions@acesaware.org. Again, that's questions@acesaware.org. If you have specific questions about California's program or would like materials that you can base your program on in your state. I also wanted to answer a question about biomarkers, where somebody asked about finding data on biomarkers indicating the efficacy of stress mitigators. And I'd like to share that UCAN is in the process of conducting a comprehensive literature review to identify and summarize biomarkers of the toxic stress response. Our findings will be included in an online ACEs and toxic stress library that will go live in 2023. The library will be housed on the ACEs Aware website. If you subscribe to our email list, you will receive notification when it's about to launch. And then lastly, we've received a couple of requests to partner with UCAN around ACEs Aware training and implementing ACE screening. If you shared your contact info with us when you submitted your question, we'll reach back to you after the webinar. If not, or you don't remember if you included your contact info, and you're interested in partnering with UCAN and ACEs Aware to implement or enhance screening in your clinic or among your network or association's members, please email us at questions@acesaware.org. And now we'll go to our final question before wrapping up. And to it. I believe we already talked about ACE screening and screening for positive experiences and protective factors. Did we not? Or at least that was one of the answers that was incorporated.
Yeah.
Okay, great. So then we do have one more question, and I will find that in Q&A. The question is, why emphasize pediatric ACE screening as compared to developmental screening? And I'll open that up to any of you. Shannon, would you like to start?
Sure, I'll be really quick. I see we're almost out of time. It's a super great question. And for the person who asked the question probably knows that there is reimbursement in addition to Medicaid capitation for both developmental screens and for ACE screens. And I've been a pediatrician for 25 years, and we've been screening for development from day one. And it's what I hope will happen with ACEs, which is that it's just what you do as part of your preventive health. And so for me, I think it's not so much that we're emphasizing the ACE screens over developmental screens, is that we want the ACE screening to become like developmental screens. We all know that, or most people know in my field, that many of the developmental challenges we see are impacted by ACEs. And so they are very intertwined, and we actually do a lot of work in the clinic where I am, and I'm sure where Makai is and where others who take care of kids are, where we make sure that we integrate the trauma and toxic stress response issues with the developmental issues and treat them together.
Great. Thank you. In the interest of time, I'm going to move on. I hope that's okay, Micaiah and Hetty. We will end this webinar by sharing resources that provide more information on the ACEs Aware initiative. We know that there were so many questions in the Q&A. We wish we could have gotten to all of them. Many of them can be answered by visiting our website and taking the training. So questions asked about what provider types can get reimbursed for ACE screens. Many of you asked about school districts. And if you go onto the DHCS website and look up LEA BOP, that's LEA-BOP, you can find out more information about school programs related to ACEs. And on this screen, you have a QR code. So if you'd like to take a picture of it, you can use that to get to the training website, or you can just go to training.acesaware.org. We encourage every single one of you to take the training, even if you are not part of a clinical healthcare team or you are not a clinician yourself. It's a very eye-opening training. The training is free, it's available online, and it only takes 2 hours. We'd also like to share a few more resources that ACEs Aware has. And if you'll see on this page, you can follow our social media accounts, you can visit our website, and you can also sign up for the monthly newsletter by scanning the QR code. And please remember to take a moment to fill out the webinar evaluation. This will be instrumental in helping us to set up and plan great webinars that are informational and that address the topics that you are most interested in. Thank you so much for attending today. Just a quick reminder, the recording and slides will be posted to the website, and we will email you once they are posted. We'll see you next time for our next webinar. Have a wonderful week.